I met most of you yesterday. For those who haven't met, I'm from Vancouver in Canada, and you'll see one of the names on this book is Kay Crosley, and she's been one of the front page editors of BJS of Clinical Sports Medicine since the 4th edition, when we had shared authors on the front, and she's been part of Clinical Sports Medicine from the start, and I'm going to share some of her work on patellofemoral pain. So this is Kay's Twitter account. I made the point you can follow world experts on Twitter, and Professor Kay Crosley is the world expert in patellofemoral pain, and so that's just another example of how you can get valuable information on Twitter, because she tweets valuable summaries and also guidelines to papers and free material. So Twitter is a signpost, and people like Professor Kay Crosley can give you these signposts. This particular talk is to revisit the consensus statement on patellofemoral pain, and I'm not an expert on patellofemoral pain, which is why I'm acknowledging those who did the work, and that's my job here today, is to bring this consensus statement to you, but on behalf of the people who did the work. So I'm not an expert, but I know what the key messages are, and we'll move through those. We see the cover of BJSM there highlighting the Optimal Loading Conference in Belfast in October, which is the second World Congress in Sports PT, and you've heard about the first one in Bern that led to the Return to Play consensus statement, and the IFSPT is a big partner in these, obviously. So the World Sports PT Congress is organised by the IFSPT, and the second one is this October in in Belfast in Northern Ireland. Really very easy, and it's a fantastic program. I do recommend it to you. Okay, so this slide set is from Professor Kay Crosley and Christian Barton, so their names are on the slide set because it's their slides. Christian Barton is a PhD physiotherapist who's now doing multimedia training as well, video, technology, journalism, and he's very committed to knowledge translation, like getting information to people, and so I recommend both of those to you to follow on Twitter, and making the point that it's their slides, and I'll make that point again at the end. So this is an open access paper, and BJSM has a policy of making these consensus statements open access, which means you can get them for free very easily. And part one was about definitions. It's very useful as well, but we're going to focus on taping, exercise, bracing, orthoses today. And Maria, who was sharing just here before, she's going to focus on the taping part. So I'm going to spend a couple minutes on exercise, because I think it's the single most important health modality, whether we're talking about cardiac disease or cancer, and certainly patellofemoral pain. Exercise therapy is the number one thing, and surgery should be avoided. What's the evidence for that? From this consensus statement, they had a bunch of experts voting on what was brought to the table, and they brought systematic reviews and meta-analysis to the table, and so you can see the green and the yellow, and if there's a green light, it means it's recommended by a world expert panel, and they're the points that I'm bringing to you. So for exercise, it's been proven to reduce pain in the short term. That means in studies where they look to see what happens in 6 months, and you know that from your clinical practice. You can get patients better with patellofemoral pain in the short term, and that's a good thing. And I'm not defining patellofemoral pain in this talk because we're focusing on treatment. This is an experienced sports PT group, so you know what patellofemoral pain is. And so the treatment is exercise, exercise, exercise. I'm going to make that point a few times. That's important because, you know, it's easy for us to say that here, but when we're out in the street and a surgeon starts to say they need to scrape away all the articular cartilage off the back of the patella, in their minds, sometimes that can make sense. And we know there's a hierarchy in medicine in the world, unfortunately, and we know there's a hierarchy in political hierarchy in Italy, and it's crazy, absolutely crazy, for an orthopaedic surgeon to scrape away the articulate cartilage of the back of a patella, pretending that's going to make the patient better. It will make the patient worse. It will make the patient an earlier candidate for a total knee replacement. But in this place, it's a safe place, we know that. When you're speaking to a tall, not that's a big deal, male or female surgeon in a beautiful Italian, suit, then it can be intimidating when they say, I think this needs to have the articular cartilage scraped away from the back of the knee with my arthroscope. So the summary slide there is that there's compelling evidence from high quality meta-analyses that exercise reduces pain and other symptoms like weakness, concern of giving way in the short term and the medium and the long term, and it improves function in the medium and the long term. So this little innovation now is talking about the hip. Physios pioneered this sort of work to look at hip stabilization as well, and I'm standing on one leg here with very good core stability and hip stability. And that wasn't in the literature back in the days when the physios pioneered it, but sometimes the research takes a while to catch up, and now the research has caught up. And again, we've got high quality studies showing that using hip exercises as well reduces pain. So the summary slide is that as clinicians on Monday, that's tomorrow, you feel very confident when you add hip exercises to the knee exercises in patellofemoral pain. And then we get to the taping part of the consensus statement, so I'm going to leave that to Maria. It's moved, I'm finally catching on, right there, Maria. And Maria's on Twitter as well, so she shares good tips for you on Twitter. I get paid a ton of money by Twitter for all new followers, so it's great. We move on to orthoses, and there's Formthotics here in the trade display, and I can recommend that display to you. There's good evidence for orthoses here, as you'll see. The good thing is about both the prefabricated one, these are the prefabricated ones that are on display here. I know the brand, Formthotics. I used them myself when I was doing this work. And you just can heat mold them with the hairdryer equivalent. And they're an effective short-term intervention. They reduce pain in the short term. And of course, when you can get pain reduction in the short term, you can do your exercises better, and you can do the quality rehabilitation, so that short-term pain relief is a good thing. So then what about combining different treatments? And education is important. We know that's an important part of physiotherapy across all domains of physiotherapy, and having the patient understand what you're doing, understand that it can take a while. That's important, and that's important in patellofemoral pain as well. And when that's been put in with soft tissue mobilisation, makes sense, and taping, that has been proven to be effective. So you'll see my very last slide says that manual therapy doesn't work because that's on its own. It hasn't been shown to work on its own. But as part of a multimodal intervention, mobilisation of the patella particularly has been shown to work. So this is great. Lots of good treatment. You can feel confident about fixing most people with patellofemoral pain. But we'll get to the difficult ones in a minute. But before we do that, we'll just talk about patellofemoral arthritis, because that's has been receiving more attention, and again is one of the areas that Professor Crosley has pioneered and has added a lot of valuable information to. And so some people think it's a continuum, that patellofemoral pain, if not managed, can lead to patellofemoral arthritis, and some people think it's a different condition. You have patellofemoral arthritis potentially as a response to trauma. So I'm not going to get into that debate, but it can make sense that arthritis generally, if you're loading tissues abnormally, like if someone has extreme knee valgus, then the loading to that anatomical structure is greater. And so we can see that if you have quadriceps impairment, poor hip control, then you may accelerate patellofemoral pain towards patellofemoral arthritis. So this is a nice trial that the Melbourne group, so now at La Trobe University and La Trobe Sport and Exercise Medicine Centre did. So we're talking about patellofemoral arthritis now, patients who are screened for that. And what happened was that they got the treatment illustrated there. They got taping as well. So this is in arthritis, which wasn't how taping was first invented. And then they got good training. So it's the same treatment program as for patellofemoral pain, but this is in proven patellofemoral arthritis. And patients have been screened to rule out tibiofemoral arthritis. And one of the key things in arthritis, exercise has to be done consistently. And the great Danish physiotherapist, Eva Roos, has shown that as well. And so here it was done 4 times a week. And you can get patients to do that by taking your time, explaining, educating. And look to see that in this particular research study, they had about 50 in each group. High quality study, randomised trial design. And I wanted to focus on these outcome measures where if we look to see on the y-axis, the green colours mean that they're doing well. And so the top category is much improved. And so we see here that in the physiotherapy group, 20 out of the nearly 50 patients were much improved, whereas with the control treatment where they didn't get the physio exercises, there was 5. And so if you look across from the left to the right, you see much better light green and dark green in physiotherapy. And not everyone gets better, and that's what is reflected in your practice. But we'll get at the end to saying those ones in the grey boxes, the 4 and the 1 who didn't do so well, don't be rushing those off to a surgeon to scrape the articular cartilage off their patella. There are other physiotherapy things that you can do for the grey boxes, but it's good to have high quality evidence that physiotherapy works in patellofemoral arthritis as well as in patellofemoral pain. And there are a lot of patients who have patellofemoral arthritis who don't have changes on the femur and changes on the tibia with their arthritis. So knee arthritis needs to be broken down to see where the main problem is, because if it's patellofemoral osteoarthritis, then non-surgical treatment can be quite effective. And in early stage tibiofemoral osteoarthritis, exercise is also the treatment of choice, but that's not the topic for me right now. And these numbers, if you, oops, sorry about that. The number needed to treat here means that in the study, if you treat 3 patients, one of them is going to have a significant clinically relevant improvement. So that's a great number. Medication usually work in the 10 to 20 to 100 if they do work. So these multimodal treatments, which I'm preferring to combine right now, work in patellofemoral osteoarthritis, both in the adolescents with the patellofemoral pain, and up to 2 years means they've been studied out to 2 years follow-up. They're still better after 2 years. It doesn't mean that they're not better after 5 years, but that work hasn't been done yet. And then they're also better in older people with the patellofemoral osteoarthritis. Okay, so last point. There are patients who don't get better, and I've made the message clear that scraping their articular surface away is not a good thing. Surgeons have fancy words for that. Surgeons say things like chondroplasty, and that's meant to imbue that with some sense of power. It's amazing the name for surgery, just a slight side diversion here, microdiscectomy. It's like, okay, it's just little, just takes away a bit of the disc, not a big deal. They're slashing into the spine. They're getting really close to the spinal cord. They're taking away the structure. It's just a massive operation. So they should say, we're about to get into your spinal cord and do a massive operation, and if your name is Tiger Woods and you're a world famous golf player, you may never be any good again. That's the operation. Do you want to have it? Or do you want to go with conservative management and see Peter O'Sullivan or other physios? But my point here is that be careful of labels like chondroplasty, that's the English term for a surgeon scraping away the articular surface at the back of a knee, of a patella, and they can't replace that with real articular cartilage. So be aware of something like that label when the trauma that the surgery is doing is real. So when pain persists in some of these patients, as you know, even with this quality evidence, then consider checking if they're doing a good job with their exercises. So now there are apps. People love to follow exercise programs by apps. They've been shown to be helpful in the short term, and then with the improvement, then they can buy into getting long-term relief. Education, really explaining why. Remember, we've got to tell a patient why. The first thing we've got to tell a patient is not what, this is exercise to do, it's why, this is why you need to do the exercise. And then they will get bought into the what. Always begin with why. Now, we heard from Nikki Phillips yesterday, sometimes you've got to sort of really customise the treatment. So if someone's much heavier, you might need to get rid of weight, and we get to that in a minute. We might need to revisit the patient at 3 months, 6 months, get them reviewed. Jenny McConnell always uses the term that patellofemoral exercises should be compared with brushing your teeth. You don't say, I've really brushed well today, or really flossed well today, I'm good for the next 3 months. Okay, we can check the translation there, that's very, very funny. So, you've got to do your flossing daily, and exercises like that, it's a good example to use with the patients. So general movement retraining, if they're loading the tissue through their work, something like that. And an amazing statistic that is true from a big randomised trial is that for a 10% weight loss in arthritis, you get a 50% pain reduction. So, we can really work, and the simple way to lose weight, as most people know, is to cut carbs. Works very effectively. The only challenge is whether people can avoid pasta, rice, bread and potatoes for ongoing periods of time. But it's a proven way to lose weight very effectively. That's not in dispute. And obviously, getting patients to understand the biopsychosocial model and their role in that is clear. So the final recommendations are that exercise in this is in patellofemoral pain, exercise therapy works. Add in the hip exercises in your clinic. Consider the multimodal interventions. The orthoses are good in the short term. So it's important to know what hasn't been proven, and that in this is the lumbar mobilisation in this case, for example. Isolated patellofemoral mobilisation, electrotherapy is rubbish. And the summary is that today, we're big on knowledge translation and empowering the patients. I just got to finish by, on knowledge translation, there are these handouts that this team have developed, that's Christian Barton and Michael Rathlaff, and they will help you put those into Italian if you wanted to. This is a handout for a patient. The details aren't important, but you can see the concept that they're giving information to the patient. And so here's another one. And so these will cooperate with you, these folks will cooperate with you. And so the last point is to acknowledge Kay Crosley's contribution, that patellofemoral pain's in the middle there, but it may be a precursor to osteoarthritis, and we really do need to customise the high quality evidence that we have in the clinic to make these patients better. And then the acknowledgement of Kay and Christian again, and saying this is their fantastic slide set, so thank you to them, Professor Kay Crosley, Dr. Christian Barton. And this is a bit more of a stretch, but if you want to get to Australia, this is a fantastic opportunity in July this year, so I know that's very soon. Thank you very much.